Well, good afternoon. My name is Mike, and I'm here with Grace and Natalie, and we'll be doing just a few points on why you might consider taking the hand and upper extremity elective course. So you might be wondering, why take it? Is it worth taking? Is it worth the extra time? Maybe how much work would it be? And so maybe to answer a few of those questions, Grace and Natalie, what are your thoughts?
So because this is an elective class, it is your choice to take it, but it's highly encouraged for people who are interested in hand therapy, or if you're not interested in going into that specialty for a career or with fieldwork, you could definitely take it if you are doing inpatient or acute care, because there's still splinting in those areas. And splinting is also huge in pediatrics as well. So if you are a peds OT, you'll definitely be seeing splinting. And then if you don't have a fieldwork rotation in hand therapy and you still want to see that, I didn't have a rotation for hand therapy, so I wanted to have something extra. So I think that's a huge benefit for that case. And then you're just making so many splints that you might not be able to see at other places. So.
Okay.
For sure. And for me, so I'm currently doing my level 2 fieldwork there right now. And if I were to just graduate and didn't have this fieldwork rotation, I absolutely would not be prepared to make a splint in inpatient or acute care or even hands. So I feel like my fieldwork experience is preparing me to actually know how to handle splints, like the properties of splints, where to cut, 50%, is it a little more than 50%? Do I cut it a little less than 50%? But I think this class will be such a great tool for everyone in this program to actually have a hand therapist there saying, okay, like this splint is great, but this is what I'd change. So it was a really hard thing for me to get like the dome, because you're supposed to have a dome on both sides of the splint. And I was like, the dome, and it took me forever to see it, but you're making like 10 plus splints in this class. And I think it'll be a really great opportunity to just know how to handle this splinting material and to hone those skills for any field of occupational therapy.
Yes, and the design of the class is it's hands-on, no pun intended, but
Right.
You're wanting to get in there and actually make the splints.
So if I understand you right, so from an inpatient perspective, so say you had no interest in doing hand and upper extremity as a career, but you want to be an inpatient therapist, you might be doing some inpatient splinting, or you might be a pediatric therapist, and you might be doing some pediatric splinting. Will there be some splints that you are likely to make as an inpatient therapist, or that you're likely to make as a pediatric therapist?
I think the two biggest would be the resting hand and like a wrist control splint. So that would also, if you're not making the splint yourself, it's important to know like the properties of why they're wearing it. Also with the class, it is case-based. So say you had a patient who was in inpatient rehab and now they're transferring to discharge to outpatient rehab, and you're seeing a splint that they came in with, different things like that. But I think it's good to know what the splint is and why they're wearing it. Even if you aren't making it yourself, making it, you want to know how to do the whole thing and start to finish.
Yeah, and I was in inpatient rehab, and so we'd have patients, I think, a handful of times throughout my time there, and my therapist wasn't comfortable making the splint, so she'd always defer to another OT. And so that would kind of like jam up this other OT's schedule, and then she'd be seeing our patient. It was kind of a big jumble, and so it would have been so much easier if she felt comfortable with splinting and knowing how to make a basic splint that is needed a good amount of time in inpatient rehab.
Gotcha. And then what about like the workload? Like, it's a busy time, whether it's your second year or whether it's your third year, you have a busy time. With all that you will have going in your second year and your third year, do you have enough time to even consider an elective?
So I think there's a great value in having it because it's diving deeper into what is touched on in other courses. As far as the actual case or like the workload, I think there's a benefit to it because you're getting that extra information. So like with the cases, you're getting to know, why am I making the splint? What is the purpose of the splint, the diagnoses that they might have, and then non-operative and operative treatment afterwards. And then also just with like you're getting so much hands-on time that you're coming to lab, having watched these videos, and then doing the splints. So there's not a lot of extra requirement outside of the lab, besides like a reading or watching a video like that. But it's just helping you to feel really prepared and confident for going into a clinic or for fieldwork or for your career.
So as a pass-fail class, you could at minimum just show up for class, still pass the elective class, have a good experience. If you choose to invest more by studying the videos beforehand, doing some readings, you could certainly do that. So you can ebb and flow that based on you have time, the time that you have during that semester.
Yes, and I think also like your motivations for taking the class are really going to show in how you are approaching the like workload. So if you're really interested, you're going to devote a lot of time to it, which I hope everyone devotes some time to it because it's a valuable class. But yeah.
And then for second years, because I'm a third year now and I only really have that to go off of, but it's during our ped semester. So all of our classes were pretty much devoted to pediatrics. And for me, like I wasn't super gung-ho peds, so I think this would have been a great addition to that coursework. So I could have something that I was really interested in and passionate about to kind of add to that semester. So I don't think it would have been a struggle to add on that coursework. I think it would have kind of made that semester, in my eyes, easier and better and just flow more because I had a class that I was really interested in.
Well said. And I think there's something to be said about it being over a 15-week period of time, right? And so you gain skill over time. And so what you come to in the first week, that skill set's going to be markedly different. Your handling skills will be markedly different because you've spent time, but also the way that you see the problem, the way that you help position, the way that you're approaching that. We hope that the cases will add context to how you integrate splinting, whether you choose to splint because it's the order, or whether you choose to splint as part of treatment. So with that said, I'd like to maybe have a little exercise here. So a good part of splinting, or effective splinting, is letting gravity be your friend. Choosing how to position the patient. Now, we recognize that in an outpatient setting, you might have more choice on how you splint the patient than you might have in an inpatient setting. So in inpatient, you might be, very, very limited because of precautions, because of IVs, because of other tubes, other things that are going on. So it may be less than ideal. So for this exercise, I'm going to give you a scenario or a diagnosis. We'll go through a couple of these. And so you've not been prepared. So this is off the cuff. And so if you wouldn't mind kind of problem solving, we'll have Grace be the patient, and Natalie will have you be the therapist. And so on the bolster, you can choose how you would like to position her so that gravity would be your friend when you're making this orthosis. The reason you want gravity to be your friend is so that the material drapes, and so that you don't have to handle it that much. You can simply apply it, work on your positioning, whatever the positioning may be, and then go from there. So let's take, Natalie, a flexor tendon injury. We'll say it's a flexor tendon injury, zone 2. And so you have an order for a dorsal block orthosis with the wrist at 20 degrees of flexion, MCPs at 70 degrees of flexion, and IP joints extended. How would you position Grace?
So I'd extend these, and then I'd flex her at her MP, and then I'd do 20 degrees of wrist flexion. So this is kind of the position we want. And so we want it on this side. So I kind of might flip her like this. So gravity can kind of just drape on both sides of the arm in this position, but we do want it flexed. So I'd probably stick her out here, bend her a little.
So great. So if it's dorsal, then gravity is going to be your friend here, right? So it's 2/3 of the forearm coming to the tips. Your wrist be nicely flexed. And so the position that you have her in, you don't have to worry about her flexion because she's naturally in flexion at the wrist and then also the MCPs. So this will really help you in this position. And so you may need other towels to help you. You also could bring her back in this position and then come here. But either one of these variants would be the position that you would want. So excellent. That way gravity is your friend. So you may start here, and then as you're positioning and you like it, you may come up here and then work to try to get that ideal final position. So excellent. Very good.
Good job.
All right. So Grace, let's say that you have a sagittal band rupture of the middle finger and an associated zone 4, zone 5 extensor tendon laceration, you get an order for a P1 block. So you're going to block the proximal phalanx, number 1. It needs to be forearm based. And then all other fingers are free. So thumb is free, index is free, middle is, or ring is free, and then small is free. So your job is to hold the PIP joint, P1 specifically, of the middle finger in extension. So we want the wrist extended about 30 degrees, MCPs at neutral, IP joint free.
Okay. So I would have her with her arm like this, so we can get that forearm, and it's going to come around the finger here, so we can get that nice drape. And I would position her wrist so I can get it nice and draped.
Excellent. And so an advantage of having her off the splint would be that you can get that drape.
Yeah.
When you're on the splint, sometimes it's tough because the lateral borders grab the bolster. So one of the ways, an in-between, is you could have a thin towel roll right here so that it would allow you to encompass around that and still get your drape. And so that you can have the position that you want at the wrist and then MCP joint extended. All right, now it's getting harder. We'll do 2 more.
Okay.
All right, so Natalie, you have an individual that has a distal radius fracture. They cannot supinate their forearm at all. So they cannot turn the palm up. And so you need to be able to make a volar wrist control with their wrist extended about 20 degrees. So this will come from the IP joint crease, the distal palmar crease, 2/3 of the forearm, leaves the fingers free, leaves the thumb free. So you need to be able to make this, but she cannot supinate at all. So,
Well, if she can't supinate, that kind of eliminates it in this plane. If we put her above her head, still might be supinating. That still might be supinating. I feel like it'd be weird to go like this.
so you're onto something there. So here's a clue.
Okay.
Think of the shoulder. The shoulder rotates. What position can you get the shoulder into? So if I'm mid position here, there's no supination, and I externally rotate my shoulder, gravity can be my friend.
Okay.
Okay, so let's try that.
Okay. So if you can stand up for me, Grace, we can kind of turn. So you can't supinate.
So you may, turn toward me just a little bit, Grace.
Yeah. And kind of go like that.
Exactly right.
Okay.
So you could be here. Now gravity is your friend. She's still in neutral rotation of the forearm, but she's in external rotation of the shoulder. Okay?
Okay.
So in this case, gravity is helping you when the patient cannot supinate.
Okay.
So you don't necessarily need to think about the joint that you're splinting only. You can think about other joints to help get the desired result.
That's smart.
Very cool.
Okay. All right, Grace. And so, final one.
Okay.
You have a supracondylar fracture, pediatric patient, and you need to make a posterior elbow orthosis. Elbow flex at approximately 70 degrees, forearm mid position.
Okay. So you want it 70 degrees, you said? This is for a flexion.
Yeah, so 90 would be here, so 70 is probably about right there.
So
And it needs to be a posterior elbow orthosis.
can I have her come up
Beautiful. Up how?
onto this? So she's externally rotated and like rest it on her head to get that drape there.
Excellent. So with her arm over her forehead or over her head there, then you can use gravity just to drape it right on there, and then you're just relaxing it right around. Exactly right.
Okay.
And then if you were doing that, you would likely have her seated so that you would be taller than she is, and then you can make it easily above her head. Okay.
You can rest.
Excellent. So those are simply just a couple examples of using gravity to be your friend, to be an extra hand for you. Now, there are cases and times inpatient where you can't do some of those things. So you might change materials. You might use an ACE wrap to help hold on when you don't have gravity to be your friend. You may need an extra set of hands. You may need some of all of the above. But that gives you just a few ideas. So any closing parting comments as to why you might consider taking the hand and upper extremity elective?
I think regardless if you go into hand therapy or to another setting, you're going to learn something with handling skills, therapeutic use of self, visual perceptual skills, and different interventions that you might not see in a different setting. So yeah, I hope it's valuable to everyone else, but I think it is.
I think it's just going to be fun. And honestly, you've been teaching students forever and been in the field for a long time. And so having you as my fieldwork educator, I've learned a ton just from your experience as being an educator. And so I think having that as a teacher is going to help in all aspects of occupational therapy, whether that's peds, acute, equine therapy, who knows? But I think it'll just be a fun time and fun experience in a fun environment.
Yeah.
Great. Well, hopefully we see you in the hand and upper extremity elective course.